Hello, everyone. I hope that you're doing well. In addition to doing the year one, week one review, thought I would do a year two, week one review for the second year individual. So, uh, some of this may be applicable to those of you that have finished up your first year of respiratory school already and are transitioning already into your second year. So for us, and this is available to my students, but I'm going to make it public to everyone. And we'll also put the note in here if there's anything that you'd like to go over a concept review or what have you, but you'd like for me to try to explain. I'll be happy to do that. Just be sure to list it in the comment section and I'll do my best to manage that thread pretty well. And we'll see if I can crank out some videos that may be of assistance or helpful to you all. So our group, they'll graduate in May and they are preparing to be of our last individuals that are going to take the TMC and the CSC exam, because with my incoming cohort, they're going to take the RTE, the respiratory therapy exam, through the NBRC, which if you need a little more information concerning that sequence of events, I did a video called Respiratory Therapy School um, Year One, Week One, and that information is in there. So it's in addition to going over the course policies and procedures in week one that we had done, we did a review on PFT's pulmonary function test, and trying to kind of distinguish the differences between our obstructive and restrictive disorders, or if you happen to have uh, a situation where there may be a little bit of a mixed situation where there are some obstructive components as well as restrictive components. And pretty much for the most part with respiratory disease, we know that that's how we're going to classify things, either an obstructive disorder or restrictive disorder. So if you're an obstructive disorder, typically there's going to be some type of limitation to flow through the conduit, if you will, the airways within the lung. So there's going to be some type of issue that limits the amount of flow that can get through there, whether it's you've got some well-known obstructive disorders such as chronic obstructive pulmonary disease. There's also asthma, where we're going to have, and ultimately with an increase in airway resistance is going to come airway obstruction. Airway resistance can, or bronchoconstriction rather, you got to look at that as a basic definition of a reduction of the inner diameter of the airway. And there's really three different mechanisms that can cause that. So you've got bronchospasm, which is the actual muscle squeezing down of itself. That's going to be the case, much of the case with asthma. You can also have an increase in secretions, which also will be the case with asthma. So those secretions inside of the airway reduce the inner diameter of the airway, which is going to increase the airway resistance through that tube. Or you can have swelling or edema, which would also reduce the inner diameter of that airway. So edema, secretions, and bronchospasm are pretty much the three mechanisms of bronchoconstriction that you can get, and all of those would be pretty much associated with an obstructive type disorder. So the chronic obstructive pulmonary disease, you can have those components as well with asthma, have those components as well. Um, Typically, because of the airway obstruction, one of the things that you can recall studying and going over in the first little bit of respiratory therapy school is that with COPD, along with that is going to come a change in anatomy. So you're going to do a barrel-shaped chest, if you will, or an increase in the AP diameter of the chest. So ultimately, what happens is with COPD, when you take a breath in, and you exhale, there's going to be a little bit of gas that remains trapped inside of the chest that doesn't get to be completely exhaled because of the airway obstruction. You also have to remember the mechanics of ventilation. Inhalation is active while exhalation is passive. So you've got your active movement of the diaphragm, you've got your other muscles of inhalation that help facilitate taking a breath in, making those pressure differences so that flow can occur, because flow does not occur without a pressure gradient. Uh, so with exhalation being passive, you've got the natural recoil and elastic forces of the lung that the lungs always want to kind of go back inward. So that natural elastic recoil of the lung helps to facilitate exhalation, make it passive. So with it being passive, that means you shouldn't have to work really to exhale. Now with a COPD patient, because the airway obstruction, you may see pursed lip breathing, or you may see a tripod type position where they're trying to get a mechanical advantage so that they can hopefully help utilize some of those muscles of exhalation and get that trapped gas out. But over the course of, the progression of their disease with chronic obstructive pulmonary disease, when they take a breath in, they can't completely exhale all of the way. So that gas, that trapped gas is going to cause their chest to change configuration. You'll also see changes in the blood gases, which we'll cover that in another video moving forward. But you see that. So when you talk about lung compliance and elastance, they really are the opposite, the reciprocal of each other. But compliance generically, I tell individuals that compliance is the ability of the lungs to receive volume. So if they're highly compliant, they're going to receive a lot of volume. If you have poor lung compliance, they're not going to receive a lot of volume. And when we talk about restrictive disorders, for the most part, restrictive disorder is going to decrease your overall lung compliance. So the lungs aren't going to be able to receive as much volume. And it's important to be able to differentiate between an obstructive disorder and a restrictive disorder, and to understand and appreciate the characteristics between the two different types of diseases. And understanding compliance and elastance is going to help go a long way with that. So in speaking of PFTs, pulmonary function tests, what we did with transition, what we did and went over, and I'll show it on the next screen, the normal spirogram. So if you're looking at this, you've got normal tidal volume breathing or tidal breathing at rest. So you just breathe moving air in and out as you would at rest. And then what you may be asked to do is perform a vital capacity. So there's 4 lung volumes and there's 4 capacities. Any combination of 2 or more of those volumes are going to make up those lung capacities. Total lung capacity is going to encompass all of those volumes. So let's cover those volumes right quick. You have the inspiratory reserve volume. That is the full amount that you can breathe in on top of a normal breath. So if I take a breath in, can I take more air in? I certainly can. So that is your inspiratory reserve volume. So at the top of a normal breath, how much more can you take in on top of that? That's your inspiratory reserve volume. How much air do you move in and out of your lungs with normal breathing? That's your tidal volume. And then at the end of a normal exhalation, you are at your FRC, which is your functional residual capacity. That means that you've got an expiratory reserve volume left and a residual volume left. That residual volume is an amount of air that pretty much stays in the lung and it doesn't come out. The expiratory reserve volume can come out. So at the end of a normal exhalation, can you blow more out? I certainly can. So that's your expiratory reserve volume, and collectively, the expiratory reserve volume and your residual volume make up your functional residual capacity. So essentially, at the end of a normal exhalation, you are at FRC. With COPD, FRC tends to increase because there's trapped air that you can't fully get out. So your residual volume is likely going to increase quite a bit with COPD when you think about the overall pathology that's going on. So inspiratory reserve volume and tidal volume are going to be the 2 volumes that make up your inspiratory capacity. So now we've covered all 4 volumes and 2 of the, well, 3 technically, because I started off with total lung capacity encompassing all 4 lung volumes. Inspiratory capacity takes into account your 2 inspiratory volumes, while functional residual capacity takes into account your 2 expiratory volumes. And then we have a maneuver that you're going to have. So if you've ever done the handy, not the handy, but the easy one, bedside spirometry, if you've ever done, and it doesn't have to be the easy one, that just happens to be the one that we've utilized, but you may be asked to perform a vital capacity on someone. So if you're performing a vital capacity, you're going to coach that individual to breathe normally in and out through their mouth. And then when you're ready for it, you're going to have them take in a maximal inhalation, taking a deep breath as much as they can, and then they're going to exhale and blow as hard and as forcefully as they can, hopefully for at least 6 seconds. And then they'll follow that up so they can't blow out anymore, and they'll follow that up with a quick breath back in. And that's what you see graphically displayed right here. So the individual's breathing normally in and out. You're going to give them the prompt to take in a deep breath, pull in as much as they can, fill the lungs up as full as they go, keep going, keep going, keep going. And now they're going to blast out, blow out as hard and as long as they can, empty their lung volume, and keep blowing, keep blowing, keep blowing until they can't take anymore, and then take a breath in and start breathing normally again. So that vital capacity, what that does is it takes the patient up to their inspiratory reserve volume, and then when they blow that out, they're gonna blow that volume out, their intraventricular reserve volume, they're gonna blow their tidal volume out, and they're gonna get rid of their extraventricular reserve volume. So they're gonna go all the way down to the residual volume, which does not come out. And then they'll return back to normal tidal breathing. In doing that, you're going to get a couple of different things. There's going to be some items that will help you with looking at a PFT result to determine if you've got obstructive versus an obstructive disorder versus restrictive disorder. So in that initial burst out, you're going to get an FEV. So you get your forced vital capacity. You're also going to get an FEV1. That's forced expiratory volume in 1 second. A lot of times you'll look at the FEV1 FVC ratio. And pretty much the magic number of that determining your obstructive disorder is going to be 70%. So if it's less than 70%, a lot of times that's very indicative of an obstructive disorder. I should have loaded the algorithm. However, if you happen to have Egan's fundamentals of respiratory care in the PFT chapter, I know you can look at that very algorithm that I'm talking about. And once you do a few case studies and look at that, you'll learn how to kind of interpret PFT results by looking at your FEV1 FVC ratio. And you can also look at your total lung capacity. So 80% will pretty much be about the cutoff with your total lung capacity, and that'll help you determine if you're not meeting up to 80% of your total lung capacity, then that might be more indicative, say, a restrictive disorder. So that was the review that we had in our first bit in our critical care concepts class. I'll continue these moving forward. And again, if you've got concepts you'd like me to go over or try and explain, I'm happy to do that too. Just list it in the comments and I'll try to be good about checking those so that I can hopefully provide some meaningful information in these videos as I go through and complete those for you. Thank you all for your time. I hope you have a good day.